Hi, I'm Ralph Preston, and welcome to another Stroke Buddies Stroke Survivor Support Group meeting. I've been looking forward to this meeting because we've got a lot of stroke survivors and also people who know a good bit about the subject. So I thought to keep things moving along, I thought I'd just quickly introduce everybody. I'm going to go around the horn. We've got Mitch Raymond. Mitch is a stroke survivor, had a stroke when he was 6 and became a physical therapist. He's a big contributor to the stroke community. He's been real helpful to our community. Dr. Hetler is also a stroke survivor. He and I both had a right side hemorrhagic stroke to our thalamus. And Dr. Hetzler's done 7 presentations for us. He's a retired neuroscientist, PhD. We got Chris Moore. Chris helps me with our website, and I've been trying to find an answer for this for you, Chris, for hypertonicity since the first time I saw you post in Stroke Buddies about 5 years ago. So maybe we can shed some light on the whole thing for you today. And then John Kopka is a friend of mine and an occupational therapist that I met through SABO. And Chris is also a stroke survivor. Everybody but Tom here is. And Tom, we don't want you to have one just to join the club that none of us wish we belonged to. And John Kanopka is a TBI survivor and an occupational therapist. Rachel Jarmos is also a stroke survivor and a yoga teacher, and she has done a number of presentations and yoga classes for our community. And Tom Haynes is a neurophysical therapist in England who has graciously shared his knowledge with us 3 times before. So that's all the players. And unfortunately, David Dancero, or his wife, has some kind of medical emergency, and he couldn't be here. He's also a physical therapist who had a stroke, and he actually returned to his practice. So, Mitch, I think you were going to start us off with, I asked a bunch of basic questions to kind of provide a forum for this meeting, and Mitch took it on himself, so I was surprised to answer most of them. So he's going to go over a few things about what is tone, what is spasticity, what is hypertonicity, what's the difference, things like that. So I'll get quiet now and let Mitch go, and if anybody in the group wants to interject or add something, feel free to go right ahead and do that.
All right, so I'm going to start off by just discussing the 3 different types of inputs that influence muscle movement within the human body. There are 3 of them. So there's activation, there's inhibition, and there's reflex. The 2 inputs from the central nervous system are activation and inhibition. And that governs volitional motor control. And then there's reflex, which is basically involuntary muscle control. So a good example of that is you go to a doctor, they come at you with a rubber hammer, they hit your knee, patellar tendon, the tendon right below your knee, your knee pops out. You don't tell it to pop out, it pops out on its own. So reflex activity is a large part of why hypertonicity happens. Basically, a good way to picture a reflex is you go from the stimulus sends a nerve signal up to the spine, reverberates back to the muscle, and activates the muscle without intervention from the brain. let's see. I'm going to go right to Ralph's questions now. Let's see. So he's first asked, what is tone? And I answered, tone is the tension in the relaxed muscle or the resistance felt by an examiner during the passive stretching of a joint when the muscles are at rest. Then he asked, when is it excessive and how can you tell? I answered, when muscle tone is excessive, this is hypertonicity. You can tell when muscles are hypertonic, when there's stiffness or lack of range of motion. What is hypertonicity? I said hypertonicity consists of exhibiting excessive tone or tension. It is a spectrum of muscle tone disorders that include spasticity, rigidity, and dystonia. So what is spasticity? Spasticity is velocity dependent hypertonic resistance in one range of motion. I'm actually going to demonstrate this. So I have spasticity in my biceps musculature. So if I go high velocity into elbow extension, it catches and then I'm able to go through it. Okay. But if I go slow through that range of motion, I don't get that catch, or not very much. What is rigidity? Rigidity is hypertonic resistance of musculature, basically in all ranges of motion. So whatever range you move the joint in, you exhibit stiffness. And then there's dystonia. Dystonia is a movement disorder that causes muscles to contract involuntarily. This can cause repetitive twisting movements. The condition can affect one part of your body, which is focal dystonia, two or more adjacent parts, which is segmental dystonia, or all parts of your body, which is general dystonia. The muscle spasms can range from mild to severe. They may be painful. They also can interfere with your performance of daily tasks, and really all of these can interfere with your performance of daily tasks.
Could I interrupt for just a minute?
Sure.
Would dystonia include clonus, where your affected limb shakes in a rhythmic fashion?
I'm not sure about that. Tom, what do you think? In dystonia, does clonus overlap with dystonia?
So clonus overlaps with spasticity. So
Okay, that's what I
effectively,
figured.
clonus is active when a muscle is sustained under quick stretch, and effectively certain muscles in the body, the reflex arc that Mitch was talking about with the reflex hammer, the stretch reflex not just exists in relation to tapping of a tendon, but also mechanical stretch of a tendon. And when it comes to the calf muscle, the wrist muscles, what typically happens is when you sustain the stretch, you get the stretch reflex initiate. But because the tendon of that muscle is particularly dense in inhibitory fibers, you get a quick inhibition of the stretch. So then you get a quick contract, relax. But then because the examiner's holding the stretch, it goes back into contract. And you effectively are just cycling between on and off spasticity. That's effectively what clonus is.
Yeah, it's like a reverberating rubber hammer to the knee.
Yeah.
You keep hitting it.
And Mitch, before you go on, there's a certain amount of tone in non-stroke body, right? Tone is something that our muscles have a certain amount of in order for us to control them.
Absolutely. So when you stretch your quads, you stretch your triceps, your calves, and this is normal everyday people. The first phase of every stretch is a muscle guard, and a muscle guard is essentially a reflex tone kicking in, and it's a protective mechanism to protect your muscle from injury. And this is why a lot of stuff that we'll get into this later, but a lot of these interventions that apply to us in terms of proprioceptive neuromuscular facilitation, contract, relax, work on the layperson. They work on everyone else too, because there is reflexive tendencies in the form of muscle guarding for non-stroke survivors as well.
Okay, thanks.
Okay. So I'll continue. Let's see. I put this in because I just wanted to put some clarity. What is hypotonicity? It is low/below normal muscle tone that can lead to excessive muscle weakness and difficulties maintaining posture. So, like, for example, when I had a stroke, I had complete flaccid paralysis of my right side. Like, I couldn't even sit up in a wheelchair. I had to have go into long sitting in a lay down wheelchair because of hypotonicity.
Could I just interrupt for a minute again?
Sure.
That Brunnstrom number one? Go
That's
ahead,
what I was
Doctor.
going to say. That was probably Brunnstrom stage number 1 of flaccidity.
Do you know all the Brunnstrom stages? I don't know them off the top of my head.
Well, there's 7 of them. The first one is flaccidity. Stage 2, spasticity appears. Stage 3, spasticity increases. Stage 4, spasticity decreases. Stage 5, spasticity continues to decrease. Stage 6, spasticity disappears. Stage 7, you have normal movement.
Gorgeous. Thank you, Bruce.
You are welcome.
So where's the line between them? How can you tell if you have hypertonicity versus spasticity? Again, spasticity is a type of muscle tone disorder within the spectrum of hypertonicity, so it's not one or the other. I liken it to, like, my wife is an occupational therapist, deals with sensory integration. She deals with autism. Autism is in a spectrum. If you have Asperger's, you have autism, but you have Asperger's within the autistic spectrum. So if you have spasticity, that's just a type of hypertonicity. Is the cramping? Stroke survivors sometimes get spasticity. I said cramping is a maximal reflexive spasm that occurs in response to overstimulation of a reflexive nerve loop. It can occur due to overflow/irradiation from excessive effort during a resistive muscle action. It can occur in response to a stretch applied to a low threshold reflexive nerve loop area. It can also occur due to excessive stress from a fight or flight response. So if you're really excited, a great example of this is, for me, it's kind of funny. If I go on a roller coaster, and you know how at the end of roller coasters, sometimes they have those cameras that take a picture of you. And when that happens, my arm is always in like flexion synergy up here as I'm kind of like, whee, going through the last of the roller coaster. Ralph, you were going to say something.
I got rid of most of, I guess I consider myself a stage 6. I don't know whether there is any such as, Brunnstrom didn't have a stroke, so I don't know if there is such a thing as number 7. I guess I've seen a few people get there. I say I'm a 6 or 6.5. So I don't have spasticity on a normal basis. I notice sometimes it comes in when I overload my brain, like going up the steps with no handrails and things in both hands. But the one time I do get it sometimes is in the morning when I'm just laying in bed when I wake up. I get like my leg wants to stretch out and I got to be real careful not to get cramps. That's why I asked that question.
Ralph, could I interrupt?
Sure.
When you yawn, does your affected limb move?
It did when early on, I could not, Bruce, I could not get my hand off of my thigh, but I would yawn and my arm would go all the way up, all the way like that. And then it would drift right back down and I couldn't do anything with it. Now I've been told it's a reflex. Mitch may know more about and Tom may know more about this than me. In discussing this in the groups, I've not found, I could not harness it in any way. I couldn't move my hand again. I had to yawn again. I couldn't fake yawn and make it happen either. You know, no, couldn't do any of that. And I've discussed it with a number of people and nobody said they could do anything with it as, you know, use it as the tool. One guy said he could, but he failed to explain how he could. So that's what I know about that.
Well, I was going to say, if you yawn now and your arm does not move, I would say that means you no longer have spasticity.
Well, I don't, because my arm doesn't move. Yeah, actually, well, this is a real aside. Sometimes in the morning you yawn, but you do this, and that's pandiculation.
Thank
But
you
I
very
don't
much.
know.
We will be touching upon that later, Ralph.
Okay, I figured would get a little bit of that in.
Okay, we are almost done with Ralph's questions. So, does stretching help spasticity? This is it has to be conscious. A lot of my fellow therapists do this kind of passive stretching, and the individual could be watching TV while they're stretching out the hand. That really bothers me because the injury is not to the hand, it's not to the foot, it's to the brain. There needs to be focus. So what I wrote down here is stretching helps spasticity only if you are consciously engaged in the inhibitory aspects of the stretching process. The process of stretching spastic muscles can be further helped through relaxation into parasympathetic stimulation of exhalation of each breath. So you have to be conscious, and if you can integrate your breathing into that inhibitory process, that helps. How do
Mitch,
Go ahead.
just one thing. I've seen a number of people say that stretching. I mean, they're not talking personally. They're saying that they're acting like they're stroke survivors, and won't name anybody. They're acting like stretching doesn't do any good for spasticity. So I would have to assume that they're maybe not actively engaged in it, or engaged in it in a correct way.
Or in
That
a
they feel
passive
that
way.
way.
I can a lot of my fellow stroke survivors, they stretch out their hand while watching TV, and it's a very unconscious process, and then they wonder why. Like, they may get a little range of motion, but it's not really, there's no real big gains in it.
If I could interrupt again, Peter Levine, who wrote Stronger After Stroke, has a blog. Well, it's not updated anymore. He passed away a couple of years ago.
Yes.
But in that, he lists things that work and things that don't work in treating spasticity. And he points out that stretching in and of itself does not help spasticity. The key is to use the affected limb or fingers or whatever. Stretching, I think he said in describing this, you'd think it would help, but stretching does not help, and also splinting does not help.
I agree with that too. And what he mentions, and this is what I support as well, is it's not just general use, it is meaningful use.
Mhm.
It's that meaningful use that is the key.
Okay.
Tom raised his hand.
Thank you. No, I think Dr. Hetzler, I completely agree with you. I think the theory behind how stretching helps, it helps on a temporary basis. If we think about why we have spasticity, it's a dysregulation of what we call descending motor output. So effectively, when you lose the motor cortical system to a degree, you have an unopposed involuntary system of muscle tone that's often activates the flexors of the upper limb and activates the extensors of the lower limb. The only way to truly address the imbalance is to develop cortical spinal activity, which is to reinitiate voluntary motion. So the only true inhibition is pure motor recovery. That's how we rebalance tone. The way that stretching works, if you think as the problem of tone initiates from the brain, stretching basically exploits a natural inhibitory system at the spinal level, but the descending imbalance still exists. So when you do a stretch, even if it is PNF stretching, you're generating different mechanisms of muscle inhibition, whether it's what's called autogenic inhibition, reciprocal inhibition, whether it's just Golgi tendon body inhibition. And what will happen is that you'll relax the muscle temporarily by quietening down the alpha and gamma neurons at that specific spinal segment. But the moment something occurs where the descending activity reinitiates, whether it's something autonomic based, such as a cough or a sneeze or pain, or whether it's voluntary based in relation to a disturbance of your overall posture, you'll notice the spasticity will simply re-emerge again. But stretching in and itself is useful for a number of things. It prevents secondary contractures, because if we don't stretch the spastic muscles, the non-contractile tissues, so the fascia, the ligaments, tendons, joint capsules, they will become inherently stiff, which will not only limit your ability to do voluntary based exercises, but even if the spasticity was to naturally reduce, if the brain is neuroplastic enough to re-establish control, you're then left with the same sort of stiffness that someone who's broken a leg and has been in a cast for 6 months has. You're still left with that passive resistance to stretching. The other aspect of it is the theory of how it can permanently help spasticity is very unproven, but the way that the model goes is that if you can reduce the firing rates of what's known as your muscle spindle within your muscle fibers, then you can reduce the amount of input that comes from the periphery that can initiate spastic reactions. So the theory goes, if you can elongate muscles, you can stretch the contractile and non-contractile tissue and deform them into a state of increased pliability, it is less sensitive to initiate a stretch reflex. So therefore, the descending dysregulation will have a lesser effect on causing spasticity. But I must stress that that secondary approach is not proven, and it's more of a theory. It's a construct. I mean, just circling back to the original point, the only true meaningful way to treat it is to facilitate strategies to inhibit spasticity temporarily, so that you can then engage, as Mitch said, in meaningful based activity. And it's the second part of that that actually corrects the spasticity.
I would agree. And Edward Taub, who developed constraint-induced movement therapy, felt that the way to overcome or deal with spasticity was to increase the cortical representation of the affected limb. And the way you do that is by using it. The more
and there were various methods, there were various rehabilitation concepts of how we achieve that. You know, you have your neurodevelopmental approach, your proprioceptive neuromuscular approach, you have your Bobath systems approach, you have your Brunnstrom approach. There's no one right approach. It's what works for the individual, because what you'll often find is studies that look at comparative analysis of outcomes, motor outcomes in patients where different subgroups have had different purist approaches, whether that's constraint induced, whether it's PNF, whether it's Bobath. You'll find that they all have very similar motor outcomes. There's no one preferential method. There's different countries have different training preferences. But what we look at is, when we look at it from a purely statistical point of view, there's no real difference. They all help. And the heart of it all is whatever helps to improve cortical representation will increase the corticospinal system's drive, and that will subsequently have an inhibitory effect on the gamma system that is being overactivated by the unruly reticulo and vestibulospinal tracts. So that's effectively so without going too much into detail, it's like you rebalancing the seesaw.
I have a personal account to kind of illustrate what both of these fellows are talking about. So I have inhibition techniques that I apply to myself. They're based on PNF. And they are all great at loosening up my hand, but they never stick. However, recently, actually over the past couple of years, maybe over the past 5 years, I intermittently go to this upper extremity boot camp put on by the occupational therapy department of Ithaca College. And basically it's constraint-induced movement therapy. It's a weekend of constraint-induced movement therapy. And so I prep my hands with these inhibition techniques, and then do this forced usage of my right upper extremity through the boot camp. And that is how, I don't know if you can see, that is how I regained my pincher grasp. My right hand used to be in a clenched position, actually ulnarly deviated, flexed, like in a fist. And now I have my pincher grasp, and I can use that quite functionally. So I know personally, sorry about that. I know personally that what Tom is stating and what Bruce is stating, it's the truth. You could stretch as much as you want. You can do inhibition techniques, all these fancy techniques, but that is only preparation for the actual application. If it's the leg, it's walking, balance, going through obstacle courses, doing whatever is at your level. If it's upper extremity, it's functional reaching, manipulating, moving, that sort of thing in a meaningful way.
That's a very, very good explanation, Mitch. Thank you. I think that's perfect, and it's not just a misconception among patients. It's a widely taught misconception in therapy. I've worked with therapists that swear stretching has permanent, meaningful impacts, and what we know is you look at any peer-reviewed RCT or meta-analyzed group of data, and you'll know it doesn't have any bearing at all. It's purely as a warm-up. It's purely as trying to set a background of normal muscle tone so that you can have the best opportunity to develop movement patterns that are representative of, quote, normal, so you can develop better use.
Okay, so go ahead.
I kind of want to add just a very brief, my perspective is very different from everybody's here because I'm on the yoga side of it. So I'm not on the medical side of it. But what I'm hearing is that, well, a couple things. Restorative yoga is something that you get into a pose, get into a stretch, and stay in. Right? It's a very passive way of doing yoga, and it's very helpful for stroke survivors. There's no research, though, not because it doesn't exist, but because nobody's doing it. It doesn't mean that it's not true. It just means that we don't have the research to back this up. My point is that I do, from the yoga perspective, believe that there is absolute benefit to stretching for the nervous system. You are relaxing your nervous system. You are allowing space to come in, to flow energy, to flow into the muscles, to get those neurons and those nerves back. Restorative yoga is something personally, and I just wonder if anyone has done it or studied it or is interested in it.
If I could,
yeah.
Go ahead,
Sorry,
in
John.
support of that last statement, one thing that I found, which goes along with the whole neuroplasticity thing, and what we were talking about with Taub, is where there's intention and attention, it drives brain neuroplasticity. And so in support of that yoga, I believe, where people are actually paying attention and becoming more aware, you are driving that, you're lighting up that whole cortical area of, or let me say, directing where you want the change to happen. And so I feel like that's very supportive in yoga. And that's maybe, when we're stretching, even though and I agree with everybody here, we don't see permanent change, but maybe it's lighting up that cortical area to say, hey, we're preparing for something to happen here.
Oh, sure. I would bet all the money that I had in the world on that theory. It's just not being studied. Nobody's studying it. Nobody seems to care. So we're all ignoring the fact that there is something to be said for sitting passively in a stretch with the intention to send energy there, with the intention to relax the muscles. And what I'm not hearing a lot of is, what about the nervous system? Stroke is it's all about the nervous system. So do we not want to balance the parasympathetic and the sympathetic systems and how do you do that? Through relaxation. Yeah. That's the only way. You're not gonna use weights. You're not gonna do a million restrictive therapies to get your nerve. Actually, what you're gonna do probably is you're going to aggravate your nervous system, making that spasticity worse, making the hypertonicity worse. And this is what I don't understand necessarily about the stroke community, is where is the focus on, like what you just said, John? The intention, sorry, I had to look at your name. The intention-based therapy, the relaxation, the close your eyes and breathe, the exhale, the inhale, all of that stuff is simply being ignored. And it's really reckless, in my opinion, because people are suffering
Rachel,
from this.
I'm just gonna chime in here. I did talk a little bit about this earlier about the importance of being conscious when you're stretching. And there is a neurological process that occurs. In fact, any stretching that's going to have any weight in the stroke post-stroke community, in the therapeutic community, you have to be conscious of it. You have to breathe into it, and that's essential within the main element of yoga, as you know. I personally have done yoga before, and I've integrated my inhibition techniques within yoga, such as alternating isometric inhibition, also pandiculation, which is more like a yawn stretch. And of course, breathing. Breathing is essential, and conscious release into the range of motion. Like when I'm trying to open up my spastic hand, I'm not just breathing into it, but mentally I'm imagining, like, maybe if I'm trying to open up my hand and with my palm in a supine position, a palm up position, I'm imagining a ball rolling off of my hand as I try to open my hand. So there's a lot of different things that go into trying to increase the range of motion. But as we said before, even though it's very beneficial, it's not permanent. And the only way to make it permanent is through the meaningful application of your motion. Not to say that yoga does not have any validity, because it is just like all the other modalities, whether it's PNF, it's bow bath, all those things that Tom mentioned. Yoga is another one that's fantastic for preparation for motor movement. And is, you do yoga, and then you should, in theory, if you're focused on your legs, you should try maybe some slow motion Tai Chi walking within parallel bars, or get in the pool and try to walk around, or whatever level you are at. You need to functionally and meaningfully apply your new range of motion that you just released through the modality that you did in preparation for that activity.
I totally agree with that. I'm not disagreeing that the conscious movement part of it is not important. I'm just saying we're ignoring a whole body of tools that I think are very beneficial to stroke survivors. When you talk about the nervous system and relaxing, a restorative yoga class where you're just sitting, breathing in different postures, in different positions, can be very helpful. Sorry, Ralph, go ahead. And I see another hand. So
Tom raised his hand, but Dr. Hetzel was trying to say something a minute or two ago, perhaps about mental imagery.
Well, yeah, there are a couple of things I'd like to comment. One is mental imagery, and studies have shown that mentally imagining using the affected limb will activate the same areas of the brain that are activated when you do use that limb. So mental imagery is something that can be used in addition to actually moving the limb in restoring its function. Now, there is a study that Edward Taub published. I've got a slide for the results somewhere. I don't think he compared yoga per se, but he randomly divided stroke patients into two groups, and one went through constraint-induced movement therapy for 2 weeks, I think it was. The other group did relaxation and psychological counseling. and they looked at the outcome on the affected limb. And for the group that got the constraint-induced movement therapy, there was a dramatic decrease in spasticity, which persisted after the study stopped. For the relaxation group, there was no change over the course of the 2 weeks in terms of the spasticity. That doesn't mean it may not have been psychologically helpful, but if you're talking about changing the affected limb, you have to induce changes in the brain that alter that homunculus, that body image. And ultimately, at the cellular level, you're increasing BDNF, brain-derived neurotrophic factor, which in turn is increased by cyclic AMP response element binding protein, CREB, which in turn is produced by cyclic AMP. So you have to go through this series of biochemical changes to produce the change in the image in the brain. And just doing yoga or something, in my opinion, is not going to facilitate that.
But it may prepare you for that. Tom, go
Yeah.
ahead. I really want to hear your input on this.
Yeah, so I would be the first to say that I think that a holistic approach to stroke rehabilitation is completely essential. It's very important. Stroke, I've not suffered one. I know you guys can vouch for the time you have a stroke. It can be quite a catastrophic experience, both physically, socially, psychologically. And we do know that movement, whilst we can schematically represent it with lots of different circuitries, we do know that there is motivational and emotionally derived movements. We do know that the sympathetic nervous system and the limbic system has an influence on movement. We can see that with spasticity being influenced by periods of distress, upsets. It can be worsened by psychological factors. So I think that anything, including relaxation and yoga, would be a really useful tool as part of an overall approach to rehabilitation, because I think if you can minimize anxiety, you can minimize stress, you can improve body acceptance, you can improve awareness of the body. That is a really essential proprietary tool to minimize overactivity within the nervous system. I think where it's the simple line is drawn is that won't necessarily improve motor outcomes. But if we just look at the recovery unidimensionally, we can't just strike off and say, Rachel, that yoga doesn't help the stroke patients. I think it does. I just think that we can't apply it necessarily directly to a motor outcome. I think we can apply it to the overall.
Yeah. I would just argue that how do we know? There's been one study done that we know of that showed that it didn't actually reduce spasticity. One study. And that's what we're basing all of these years of research on. That doesn't seem very intelligent or very smart at all to like, because people are not actually studying. I mentioned restorative yoga only because it helps me a lot. And I teach it and I see that it helps other people as well. But yoga is a very broad spectrum. You're not just sitting and breathing doing yoga. You can be doing very active things, walking, warrior poses that build strength in the legs. But my point is, how do we know? We're all just throw the towel in and say, oh, there was one study done and it showed that it didn't. Okay, so then we check that off the list. That is not.
There are many studies that show the effect of stretching in long-term motor outcomes, and I think that obviously that's stretching. There are different varieties, but at the core of it, stretching can be shared by a number of different approaches, and we can see that there's no lasting spasticity and motor outcome benefit. But that's not to say we're just not measuring the right outcome to see its benefits. I'm sure there would be plenty of studies that would vouch for the effect of yoga on other dimensions of recovery. And that in itself validates everything for you.
That's my point, though, is that I've done endless research looking for the studies that show whether or not this actually helps. I'm all on board with something that is showing that this helps in this very, specific study-based presentation. My point is that it doesn't exist. There's nobody doing it. There's
Rachel, let me just chime in here, because there's a number of different modalities that don't have a lot of research. Acupuncture is another example. And then some people swear by it. And what I found is, like, I even have some interventions that I would love to put through the mill of peer-reviewed research, but I don't have the time, I don't have the money to be able to have. I've actually tried to talk to a local college of mine nearby me to see if they would adopt it, and they had too many other things that they are trying to do tests and measures on and do their own research on. So it's I know that my stuff works, same as that your stuff works in terms of preparation for the functional task, but there's just not enough resources, enough money, enough whatever, maybe enough interest per se for these interventions to be really thoroughly reviewed.
Yeah,
and so what I would like to just do is have Tom say his piece, and then I would actually like to this is a brilliant segue onto interventions. And so Tom, why don't you say your piece, and then we'll transition on to intervention.
So anecdotally speaking, even myself, I do use lots of inhibition strategies. Even, I work clinic all day today, and I'm thinking through the stroke patients that I've seen, and massage featured quite heavily. So did passive inhibition stretching, but it's always part of this kind of proprietary setup before we end up doing the functional based active kind of therapy. And sometimes it makes part of a warm down as well, because then the active therapy can interplay with unmasking certain tones. So I just think that you don't necessarily have to research a specific construct if you've already researched the concept. I think that's where it is at the moment with the body of research. It might be something that does get funding for it and looked into, but I think people need primary proof of concept in order for research to then want to take on something more specific. I think that's what I would say. It's not that there's anything against anything. I know there's lots of bodies of research around the use of Tai Chi, for example, particularly with Parkinson's patients, and often the more common balanced rehabilitation protocols for neurological diseases, things that are globally quite well known, like the Atego program and the FLAIR program. They all use elements of Tai Chi because of the studies on that. But I think, I don't know, I'm not much of a holistic therapist, but I know that Tai Chi has, as I presume, more active components than stretching alone.
Well, but
so
can
I guess
we not say that relaxation itself is healing?
Absolutely.
Yeah, of course.
We aren't denying that, Rachel. We aren't denying that.
Oh yeah, 100%.
The body.
Well, the other thing is Dr. Taub didn't study yoga; he studied relaxation techniques. So
right, that's more of like the
essentially there isn't like one study. There may be no study.
Right. We know that relaxation works in specifically in a stroke survivor's body to heal, and really in anybody's body healing. So coming from that place of, okay, we know this, then we can kind of jump into, well, if you're doing passive restorative yoga, you're relaxing the body, therefore you're healing.
Yeah, you're healing. But Rachel, are you saying that yoga itself, without doing anything functional, is the cure-all for post-stroke maladies?
No.
Okay,
No.
all right. I'm just making sure, because then what we're saying, we're basically
there does, in my opinion, need to be less focus on the active work when it comes to stroke rehabilitation, that we can be focused more on the relaxation portion of it and find out where that leads. Yoga is not the be all end all of anything, nor I do believe that that will solve any problems. I'm just saying that this to me seems like a perspective that nobody's really looking at.
Okay, so let me just I'll compliment what you're trying to say. So at the beginning, remember I talked about activation versus inhibition. You remember me mentioning that?
Yes.
Okay. So when it comes to any sort of volitional motor pattern, reaching, walking, sidestepping, whatever, opening up your hand, your muscles are varying between activation and inhibition. There isn't one muscle group that activating and the other muscle group that's totally turning off. It's a variability in a balance between activation and inhibition as you bring your joints through the range of motion. And so in order for reflex-based spasticity to be overcome, you can't just foster activation. You can't just foster inhibition. You have to foster both. And in order for, and then, with you fostering both activation and inhibition, that's just a setup. Then the next step is trying to get your extremity into a functional, meaningful sort of motor pattern that you practice consistently in order to develop a neural network that will give you direction on how to basically walk and chew bubblegum at the same time, to be more automatic with your motor planning.
Yes, I could agree with that. I guess I just think that there are a lot of stroke survivors that are not at the place where they're ready to start doing those active movements. We need to be more focused on getting them into a completely relaxed state and then move into these movements. We're jumping into the movements with somebody that is in a very sympathetic nervous system state. And in my opinion, when your body is in that state, there's no point in doing anything really other than just relaxing and getting it balanced into the parasympathetic and the sympathetic.
It's a case-by-case basis. There's not stroke survivors that are all sympathetic. There's not stroke survivors that are all parasympathetic.
There's sympathetic symptom of the body. So why are we not treating it?
For those who don't know sympathetic versus parasympathetic usually is relaxation, release, and sympathetic is excitation. I say this to my clientele all the time. If someone comes up behind you and goes boo, and you inhale and you hold your breath, what do? You tense your body. That's sympathetic. You come home at the end of the day, you sit down after and just relax, and you take a deep sigh and you go, and your body relaxes. That's parasympathetic.
If I could interrupt for just a second.
Yeah, sure. Go ahead, Bruce.
Yeah, sympathetic and parasympathetic really is referring to the two divisions of the peripheral nervous system, of the autonomic nervous system.
The autonomic, yes.
The autonomic. So the sympathetic nervous system is active when you're under stress,
Correct.
the so-called fight or flight response.
Correct.
Your heartbeat increases, your blood pressure increases, you breathe more heavily. When you calm down, when you're relaxed, that's when your parasympathetic nervous system takes over. And that's when you digest your food and have to go to the bathroom and so on. Mm-hmm. You calm down. So your autonomic nervous system has those two divisions. And the sympathetic portion of the autonomic nervous system is active when you're under stress. And it's not healthy to have your sympathetic nervous system activated for a long period of time. That can cause a number of disease states. So yoga can help shift that over towards the parasympathetic portion. Also, I should point out, and I think I've got the number right, but I could be wrong. I think about 60% of stroke survivors have depression, and something like yoga could help them perhaps deal with that depression, which might in turn make them more susceptible to their therapies.
Okay.
That's a good point too. I think that that is, yeah, kind of going back to what I was saying about like somebody that is in that hyper stress situation, you know, their nervous system is on fight or flight all the time. Your body is constantly in that stress state. Doing anything with that person, in my opinion, is not helpful. What you want to do is get the parasympathetic to kick in, get them to ebb and flow better with each other because they alternate. They're kind of like one comes on, one comes off. They're supposed to go tandem, you know, they're not supposed to be just sympathetic or just parasympathetic. They're supposed to go together. What happens in a stroke body is, I believe, the sympathetic just takes over. You're constantly in this hyper vigilant, oh my gosh, self-protection mode, and you're not able to receive anything. And it's similar to depression. If you're in a state of feeling really lousy mentally, you're not going to be able to receive what a PT is saying to you about doing, you know, 10 different bridges twice a day, 3-4 times a day, whatever. That's going to go completely over your head. So I just think that we're missing a big chunk of how to help brain injury survivors by not acknowledging this sympathetic nervous system as being a real problem, honestly.
Rachel.
Not only just in stroke survivors, but in general, in society, you go out and you see people, everybody's aggressive, everybody's angry, everybody's rushing. That's the sympathetic nervous system kicking in and not balancing through that relaxation state, that rest and digest, that calm place.
I think, Rachel, we're all, pretty much all in agreement with you. We're not against you here. One of the things I say to my clients all the time is breathing itself fosters neuromuscular control. So when I'm trying to move someone through a range of motion or have them move through a range of motion, and they're holding their breath, I correct it right away and try to get them to breathe into the range of motion, because when they hold their breath, they're basically allowing reflexive activity to create muscle guarding and opposing muscle groups fire, and then they're making it more hard for themselves to move through the range of motion.
Right.
So what I would like to do next, guys, is and we're kind of already in this arena already, but Ralph's question of how do you overcome spasticity, strategies, exercises, stretching. So we already talked a lot about yoga. I would like to hear from all of you guys or anyone who wants to chime in what you tend to do, what you find most effective in terms of your preparation. I think we should probably divide it into two categories. One is preparation, and the other is application. You know, in my range series of post-stroke rehab techniques, there is increased range of motion, explore range of motion, apply range of motion. Increased range of motion is the preparation aspect, and apply range of motion is the CIMT, the gait training, the functional application. So I'm going to take a step back, and I would love for like people like Tom and John and Ralph or anybody else who wants to chime in here to chime in what your approach is to reducing spasticity.
I'll start. I didn't have access to very good physical therapy once I got out of the rehab hospital. I was in a small rural place, so I was a lot on my own. I unplugged my computer accidentally. Don't want to do that. So I kind of was, well, they send us all home to reinvent the wheel for ourselves. But I was definitely inventing the wheel because I didn't have much support. I actually had a therapist who told me that I should work on distance as opposed to form, and I ended up having to kind of start over, not truly start over, but I had to take a different focus 3 or 4 months into my walking. But what I found, what I did, and everything I did was just based on logic and my intuition. What I found was that I couldn't open my arm fully. I couldn't lift my hand off my lap. I couldn't do much with my fingers. So I worked things to get that motion back, either passively. I actually did visual imagery. But what I found was, basically, make a long story short, once I had full range of motion in something, and I had strength throughout the range of motion, once I got to full range of motion, my spasticity started slowly decreasing. And as Bruce mentioned, there are 2 stages of the 7 stages of decreased and more decreased spasticity. So I definitely noticed them, although I didn't hear about Brunnstrom until 3 years ago when Bruce did a presentation on spasticity. Anyway, I found the first sign for me was getting back to the pretty much full range of motion. It definitely started going away. And then after that, as I got kind of strength throughout the range of motion, and also like I'm doing my affected arm, I had like a bump here, and I would like work through the bump. And when I could go all the way up and all the way down and had strength throughout the entire range of motion, that's when my spasticity was pretty much gone at that point. So
Can you hear me, by the way?
yeah.
Oh, can I make a point? This morning, for instance, a classic example for me. I was having a slightly bad day, but I could still walk around the house all right, no problems. But as soon as I went out, then it really hit me hard. The spasticity, or I call it spasticity. I think it's dystonia, but the effect was much coming back to I think it's to do with the stress of walking outside rather than, because as soon as I came back indoors after I've been out, I was all right again.
Didn't you also say, Chris, you went to therapy this morning and you didn't do
yeah,
that?
That's where it kicked in.
But when you got home, you were able to
I was all right. Yeah, I was fine again there. Yeah, it's so coming back, stress is definitely something that seems to affect me. I don't know why, because consciously I was all right, but unconsciously my body didn't like it.
Well, stress, if I could interrupt for a minute, stress does play a role, but it's possible that what you're describing also is in part due to what's called classical conditioning. That's a type of learning first developed by Ivan Pavlov around 1900 with his dogs that learned to salivate to a tone and things like that. But the point is, you have associated your home, your living environment, with reduced spasticity because of what you do. You learned it. It's a classically conditioned response, perhaps. When you get in that environment, your spasticity reduces. When you go to a different environment with different stimuli, spasticity increases because it's not associated with the decrease in spasticity.
Yeah. Can I add to that as well?
I was going to say, so Tom chuckling and nodding.
I'm like a nodding dog here sometimes, but yeah. So there's a couple of points there that's definitely correct, where you learn motor patterns and you associate them with a setting. So there is definitely a link of where you'll walk the same route many times. Your brain is able to predict the environment that you're in, and you've learned specific reaction rebalance mechanisms for specific parts of your environment. So there's two parts here. When you go outside, the environment becomes less static, it's more dynamic. So it also has to take on a lot more information in order to process your balance, your gait parameters, and to adjust them real time, which you don't necessarily have when you're indoors. A car's moving, you're having to predict distance, there's some noise going off, the floor is different congruence and different elements of undulation around different points. So all of that input, sensory input, is then having to be centrally processed. And effectively, when you've got your post-stroke brain that has learned certain patterns, it can be quite overwhelming. And often there's the anxiety drive for that. And then there's also the fact that the inability to process those reactions will manifest in increased spasticity. A very good example of this that is not just seen in strokes, but I'm going to use the example of Parkinson's disease once again, because whilst it's a motor condition, we see a very common thing that happens with Parkinson's patients is they go to walk through a doorway. Okay. And when they go to walk through a doorway, their rigidity and their festinating gait magnifies quite significantly. The reason for this is because when they go to walk from one room to another, the doorway creates a new set of parameters that the brain has to visually construct in the brain. And then the basal ganglia and the thalamic loop has to readjust the gait parameters and tonal parameters. And the result is, because that loop is not working fast enough, there's an overflow of rigidity. So it's a very similar thing, just applied to the stroke situation. So that regulation of tone is not able to keep pace with the sensory input and environmental changes. It's just that instead of in you guys, it doesn't manifest as rigidity, but it will manifest as an increase in spasticity, because that's a subcategory of hypertonicity that you will experience.
Yeah, mine was a basal ganglia stroke.
Yeah,
There you
so
go.
you might experience a lot more of that.
Do you think that holds true if you're walking, and say you're walking by yourself, as opposed to if you're walking and you see another person approaching you? That's something that the brain then has to reprocess that person, so that could potentially throw off.
Well, I got this morning. I got almost frozen on the spot. I couldn't. But as soon as I just touched the instructor's arm, I was all right again. You know, I could walk quite easily then.
Yeah,
So,
that's another thing that's interesting, is if I've heard that from more than just you as well, is if someone is by themselves, but then they have someone or something to touch, that all.
Yeah.
So like, is that what you're saying, that the brain is like reprocessing all of that stuff and taking time?
well, yeah, the fear just went. You know, the fear of falling just sort of as soon as I knew I was all right. Then.
Fear itself. I just know that I do better walking by myself. If I'm walking with somebody and they're talking to me, or if I'm walking and somebody else is walking towards me, all of a sudden I could lose everything that I just relaxed simply by that person.
Yeah.
So like, what is that? That's my brain.
Cognitive overlay is the
Cognitive overload. Ralph
Correct.
mentioned
Have
it.
you ever tried to do a maths equation whilst walking? It's incredibly difficult
Right.
versus when you're sat down.
Well, I noticed when I used to walk at the beach, there was a boardwalk, and I'd be walking along fine. I'd see somebody coming towards me, and all of a sudden, I'm not walking. I'm overthinking everything, and my walking. I could noticeably feel my walking go in the crapper. Not completely, but and part of it's a fear thing, and you got the whole thing with touching somebody's shoulder. People can walk just by touching somebody's shoulder sometimes better than they can when they are all alone. So,
but do you think that it's the thought energy, that when the thought energy starts to ramp up, like when you start having more thoughts as you're walking, then the body muscularly responds to that in a negative way?
It's not only that, it's it's also just like it can be posture too. Like for example, if I want to optimally work on my hand, I find sometimes my hand can release and relax better and I can work with it better if I'm in a lay down position. If I'm relaxing the rest of my body while I'm working on my right spastic right hand, I find that I'm able to focus more. I can detach, neurologically detach from the rest of my body and only focus on what needs to be focused on.
Well,
However,
are you
if I try to do it in standing, if I try to do it in standing or while walking around, I'm not going to have as much success. If I try to do it while walking in a crowded city with people oncoming and navigate, I'm not going to have a prayer of
Yeah.
having increased range of motion.
Now,
Mitch,
one reason that might be is if you're laying down with your arm on the bed or something, you're not dealing with the effects of gravity.
Yeah. Yeah.
And spasticity mainly affects the anti-gravity muscles.
Yeah.
So that would be the flexors in
Yeah.
the hands and arm and the extensors in the legs. So if you had a cat that had a stroke, all four legs would be rigidly extended. But for a human, in the legs, it's the extensor muscles that fight the effects of gravity. Gravity pulls you down. The extending the legs keeps you up. For your hands, gravity pulls your arm down, and you fight gravity by flexing your arm or flexing your fingers. So if you're laying down with your arm by your side, you're not countering the effects of gravity. So it might therefore be easier for you to deal with your affected hand.
Tom's got his hand up.
Yeah, you beat me to it, Bruce. You completely. Effectively, without trying to go over exactly what Bruce said there, when you're against gravity, your inner ears, your vestibular system becomes activated. That has a direct link to a specific extrapyramidal pathway called in the case of your spasticity for your upper and lower limbs, your medial and lateral vestibular spinal tract. And when that becomes activated, the postural extensors become inherently more stiff. You then also got the segmental reflex of what's called your positive support reaction that happens around your ankles and knees. Collectively, the two will increase that volume of extensor tone. So if you're trying to focus on flexion activities, you're going to find it significantly more difficult to access them because let's say when you're upright, the background tone is a 9 out of 10. Meanwhile, your flexor activation ability is a 3 out of 10. The net result is you're still stuck in extension. When you lie down or when you sit down, because you're reducing the postural and gravity demand, your inner ears won't be providing the same signal. That background extensor tone will die back. So you'll notice you'll get more flexor drive of your lower limbs when you're lying down. So part of the therapeutic approach to that for people with spasticity that I take them through is, okay, so we want to work flexor drive for the lower limbs, because when you have spasticity in the lower limbs, most of you will be able to straighten your knee and you'll be able to push your toes down and invert them. But yet, if you say to someone stood up, well, bend your knee then without lifting your knee up, they'll find it incredibly difficult. But what we will do is we'll start the motor patterning in a what I quote low tone position. So we would start that in a lying or side lying posture to develop the motor patterns. And then when we can regulate that effectively, we bring the patient up into a slightly increased tonal posture where there is a higher degree of background tone. We build it up again until we can supersede the background tone. Then we bring them up into a higher posture. It doesn't mean we restrict things like walking and standing. We still promote functional recovery. But when we're at the point of Brunnstrom where we want to be reducing tonal demand and increasing what's called selective control, like you do with your fingers or whatnot, you've got to take the patient back into a low tone posture and rebuild that pattern back in again.
So I would just like to chime in here just for my fellow stroke survivors. There's a lot of stroke survivors, guys, that are in maximal spasticity. I mean, their hand is in a fist and they do not know how to get themselves out of it. I have things that I can share, but I would like to hear what Tom and perhaps John and whoever else wants to chime in. How do you get yourself out of that maximal spasticity? How do you even start when you're at maximal spasticity? So
I think there is a degree where the severity of spasticity is proportionate to the degree of specific damage within the homunculus that represents that limb. People that are in grade, what we call Ashworth scale 4, which is maximum spasticity, it's very, very hard to break that pattern up. There is going to be a degree where you can try strategies, but ultimately, if there is a lack of neuroplasticity within that area, spasticity may not be able to be reduced just with therapeutic means. It's at that point that the exploration of pharmacological mechanisms might be useful at that point. You know, I've had previous talks on the use of Botox and the use of baclofen, tizanidine, things like this. And obviously, quite early on in stroke recovery, when you can superimpose high tone with therapeutic modalities, you want to avoid those things because you don't want to reduce the ability for the nervous system to activate, which is what a lot of those things can do. But when you're in that state where no therapist can even bring you out of it, at that point, that might be something that's advisable.
John, do you have
Yeah,
any?
John, you've had people present, you know, totally balled up fists for 25 years as an OT.
Yeah, and it does get very difficult. Like Tom had mentioned, sometimes depending on the amount of damage, people almost seem fixated in that position. Then you have the compilation of that tissue shortening, which then contributes to a lot of that spasticity. But going along with what we were discussing earlier, being able to get some sort of volitional activation on a stretch to decrease that reactivity of the muscle spindle and getting the Golgi tendon organ involved. That's pretty much one of the only mechanisms I've been successful with where it's actually shown some promising carry through, actually getting the hand in there and putting it on a stretch and trying to reactivate some of that volitional contraction, and then going along with relaxation, pulling that relaxation that Rachel was talking about into it, and getting the breath in, directing the attention and focus on what they're trying to do. So that way we get a all on and an all off approach where, you know, sometimes we'll even I put vibration to the pec to really have them pull into that flexor synergy pattern to activate it so that they feel it and they have something to identify. And when they can really turn on that flexor synergy pattern and squeeze and then compare it to the breath and the completely turning off, now they have some sort of foundation baseline to work with as far as volitionally inhibiting that tightness. And sometimes that shows promise when people really put their belief into it and become active with it.
I know, I just want to mention really quick because I was in this state for probably 10 years, to which doctors, PTs, honestly did not know what to do to me. I did Botox, I did baclofen, I had a Sabo, I was doing everything that everybody told me to do and nothing was working. So that's my perspective when I get a little bit passionate about the yoga that I'm talking about, is that I've been through the ringer with this stuff. I was in a fist for, like I said, 10 years. Now I have the first ability that I have ever had to extend my fingers. Now I'm doing it manually, of course, but this is huge for me.
Absolutely.
Right here. This is huge. And this is not, no offense to anybody here, from any medical perspective, this is all yoga. And the only thing that I have done for the past 7 or 8 years has been yoga. And I have gotten myself out of, my elbow was stuck and my fist was like this at my chest, right? For 10 years, right? Imagine that. Yeah. That level of frustration, doing the Botox, doing the baclofen pump. They want to put a pump in my spine. I'm 27. I don't want a freaking pump in my spine. So I turned to holistic methods as a way to help myself because nothing else was working. Nothing else. I listened to all the experts. I did all the things. I was this close to having the tendon release surgery in my arm because I had it in my leg, my foot, and saw a little bit benefit. So I was going to do it in my arm. And then something told me, like, wait, hold on, stop. Let's not just tear the whole body apart here and start putting stuff in it. Let's try a different approach. So with yoga, I can now fully extend my elbow. I can get my arm almost to a straight position. I can reach behind my back. I still don't have function of my hand, but my theory is that I'm moving energy. I know people don't love this word, energy, because it's so like kind of ambiguous. But my theory is that energy gets stuck in different places in the body. It's stuck in my shoulder, and I have a bit of frozen shoulder just because it hasn't been used for 10 plus years. You're not using your arm. Shit, excuse my language. Shit is going to get stuck, right? So now I'm treating it as frozen shoulder, doing the yoga to release energy from my shoulder, and it's trickling down into my hand. And the fact that I can get this, and I'm shaking because it's the colonus. I just did like a 2-hour yoga session, and we were working strictly on the scapula, getting the diaphragm to breathe and move properly. And so I'm seeing, oh my gosh, I can fit my finger in there. That's huge. And that's only yoga, stretching, if you want to call it, and breath work.
Yeah.
That's it.
I'm very, very impressed. If I could, I'm very impressed with what you've accomplished. And I understand that you attribute that to yoga, but basically the yoga involves moving the arm. It's, am I correct?
Yeah, but there is also a lot of sitting.
Go ahead.
But now you just said, and this is something I wanted to mention, you just said you just completed, I think you said 2 hours of yoga. Is that correct?
Yes.
Yes. Now, one thing that is important in treating spasticity is to try to do the exercises or the yoga in extended blocks of time. What's called massed practice as opposed to distributed practice. For example, you could, rather than doing a 2-hour block of yoga, you could have done 30 minutes of yoga this morning at 8 o'clock, 30 minutes at 10 o'clock, 30 minutes at 1 o'clock, 30 minutes at 2 o'clock. That's distributed yoga in that case. Or you could have done a 2-hour block straight of yoga. And it's the massed, in this case, yoga, that's going to be far more beneficial than chopping it up into 4 separate groups.
I was also going to say here, then I'll toss it to you, Mitch, is that Rachel, the science and the yoga are not mutually exclusive. You're using some of the scientific principles that we're talking about in your yoga, like when you're talking about opening it with your other hand, that's using passive movement, which often leads to active movement. So I I don't see it as a either or thing. I'm just a lay person I've been doing yoga now about 3.5 years. I found it really interesting. I'm going to take my 5th Tai Chi class tomorrow. I think that has a lot of promise. But I think that and Thomas mentioned Tai Chi walking. We learned how to do that last week. I think that there is a certain amount of science in yoga and Tai Chi, and that maybe you should not look at them as black and white, mutually exclusive. So
I agree with that. And I see that we're all kind of saying the same thing for sure. I'm not trying to argue or disagree with anybody.
No, I'm not saying.
From my perspective, I know that physical therapy was not effective for me. It was not, it was nothing that a PT gave me was doing anything that yoga is doing for me today at all.
Well,
But that could also, I'm sorry, I'm interrupting again, but that could also be because of your interest and your attention to it. You may have thought these
I had never done
exercises
yoga prior. I have no yoga. I was never interested in yoga prior.
Yeah, but you're engaged.
But you might be interested now, whereas you think the physical therapy exercises are crap, and so you're not going to be interested in them.
But the reason that I think they're crap is because I did them for 10 years and saw nothing. Saw literally no changes.
Yeah.
Actually had PTs look at me and say, "Why are you here? Go home."
I had crappy physical therapy for a long time, particularly in the beginning, and I kind of invented my own thing. And I mean, you could say what I did was sort of yoga. Mitch is
not all physical therapists are. Yeah, not all physical therapists are created equal.
Thank you.
Tom, you can
know,
understand
and listen, I told Ralph that I would be on this call, but that I would remain quiet because I knew that my mouth was going to get me in trouble because I speak a little bit directly. And then I kind of thought, well, maybe I shouldn't be quiet. So maybe I should just go back to being quiet. But I'm not trying to offend or say that physical therapy is trash or it's crap. I just know from my experience, it did not do what it didn't. I mean, how could you dispute that? You go through 10 years of physical therapy and then 6 years of yoga, and I'm seeing much more functional movement, better balance, better muscular control, less spasticity, less brain fog, more confidence, less depression. I mean, the list could go on and on and on.
That's good. That's great.
Go ahead, Mitch.
Well, I'm just gonna. I think I want to validate what Rachel is saying, and I'm pleased that it has worked for you, and it has worked for me a little bit too. It's worked for Ralph. So, again, we're not contending it. What I do want to touch upon is a couple of the techniques that I have found that have worked pretty well against spasticity. I'm going to show them to you right now. And again, I acknowledge that this is preparatory. This isn't cure-all, but like right now, I try to open up my hand, and that's about as much as I can. I have a little bit of extension of the fingers, but primarily it's these muscles called the lumbricals that really I need to start with to open up my hand. So just so you guys know, out in who are viewing this as the general public, lumbrical stretch is like this. You're flexing the two joints of the finger and extending the knuckle joint. Okay, so if I try to go into the lumbrical stretch right now, I'm hitting a wall. Can you guys see that?
Yes.
Okay. Now what I'm going to do is what I call double click inhibition. Think of a double click of a mouse, right? So I'm going to click, click, release, click, click, release, click, click, release. Now, some kids say it's a souped up version of contract, relax. Now how many phases was that? Was that 4, 3 or 4? Okay, I'm going to go at it again. So going into the range, there's my wall. Click, click, release, click, click, release. That was only 2. Okay, well, let's try it again. Bring it through the range of motion. Feels like it's a little more give. Click, click, release, click, click, release. Still 2, but a little faster. Okay, we'll do it again. Bring it through the range of motion. It's actually giving. You see that? It's actually giving into the range of motion. Okay, so, but I'm still going to go to that first phase. Click, click, release. That was only 1. Still slow, though. We're going to go through the range of motion again. First phase, click, click, release. That was really fast. Do it again. Click, click, release. Do it again. Click, click, release. It's going faster and faster as I rehearse the motor pattern. Click, click, release. Now, I'm going to open up my hand. Do you see this? Now, my wrist is not released because those are another set of muscles. But now I'm able to, like, I have a mouse right here. I'm able to pick up the mouse and drop it with all of my fingers as a result of just releasing the lumbricals. All right. So that is just one example of increasing range of motion, but that in that of itself cannot be what releases it. In the next phase of that, and I promised Ralph I'll touch upon this, and hopefully Rachel jives with this too with her yoga. Pandiculation. What is pandiculation? Pandiculation is yawn stretching. Okay, so if you look at a cat or a dog, they take a deep breath and they stretch, right? They put their paws out. Ralph is going to call over his cat. But you can do a clinical application of pandiculation yourself. So what is pandiculation? So I'm going to do it with my lumbricals because it's easy to show on the screen. So what I'm going to do is I'm going to tense those lumbrical muscles that bring my fingers down, and actually this is the lumbrical contraction right here. The fingers are actually extended, and the MCP joints or the knuckle joints are flexed. Okay, so I'm going to try to bring myself into a fist, right? And now I'm going to keep those activated as I go against their range of motion, open up the hand while they're activated. And once I get into a stretch range, I release. Okay, I'll do it again. Contract. I shorten the muscle, concentrically shorten. And then I eccentrically still keep the resistance on, kind of crank it open while I'm still applying resistance. Once I get into the stretch range, relax. And now I'm going to go passively through the range of motion. Do you see how loose this is? So double click inhibition, great setup, great way to break through the initial spasticity. And I try to get to the point where I can do at least one double click and release, and it's good. And then I do pandiculation, which is contracting against resistance and then eccentrically elongating against the same resistance into a lengthened range. Once I get to the lengthened range, then I exhale and release and relax.
Question, Mitch. I have no exercises using these inhibition techniques. Is it something that you and I could work on, and we could show some people some simple techniques? I mean,
Absolutely.
Not here.
Yeah,
Okay,
you could. Really I actually, to my local library, I'm doing a mind over body class that applies not TikTok inhibition, but alternating isometric inhibition as an introductory into the new range of motion, and then pandiculation to kind of solidify it. So yeah,
John, your input on that, on all this might be valuable too. Sorry. You're done.
I've used very similar techniques in the clinic, and it absolutely works, especially that stretching, and then stretching while somebody's contracting, and then the volitional inhibition or just purposely relaxing. It's you see like instant changes, and I feel like when a survivor sees an instant change, there's not only buy-in, but there's like some hope there, like, oh my goodness, I caused this change, and then it kind of initiates some exploration, some play, some curiosity. And with going with what Rachel said, and with, there's all different types of therapy. There's some therapists that go to the job to get their paycheck, to go through an exercise routine. I always joke around and say 3 sets of 10, here we go, because life isn't about 3 sets of 10. But if as a child you were forced to play with the same toy all the time that you didn't really have much interest in, your brain's not going to grow. It's not going to stimulate all the areas that you have. And so with yoga, obviously has stimulated a part of her brain. She sees a difference. She sees a change. And I would go with that 1,000%. I mean, obviously it's helping. And then to branch off of that, because it's affecting her spasticity, it's affecting her mood, it's affecting her whole being. And she's incorporating the breath, she's incorporating, volitional relaxation, she's incorporating all these other techniques and strategies that as therapists, neurologists, that we know work. But the bottom line is, as humans, when we have a curiosity or an interest in it, we see brain change. And that's ultimately what we want.
Well, and that was my point about them not being
But I-
mutually exclusive. Rachel, I'll let you talk in just a sec. But one thing, anybody who knows me knows that I believe that a lot of our healing goes on at home with things that you can do on your own without $80,000 robotic devices and stuff. So Mitch and John and I could make some videos that would show people how they could use some of these techniques on themselves at home. That would be huge.
MacGyver PT, baby.
What I was gonna say was that, the cool
All right,
thing
Rachel,
about it-
you
the
had
cool
something.
thing about it is that I kind of started yoga strictly as a thing for myself, right? I was frustrated with the medical community. I wanted to learn more. I had no idea what yoga was. I went in pretty hard to learn, got my teacher training, never really wanted to teach because I thought, this is me. This is my belief. I believe in holistic healing. I believe in this. I'm going to stick with it with me. What I found was that it works for literally anyone. These breathing techniques, you can literally train your body to with an inhale and an exhale to release this.
Yeah.
You're not buying anything. You're not going anywhere. You're simply sitting at your house using your breath to inhale and exhale and release this, right? To get this. And I've seen it happen with many people, that it doesn't take much awareness to bring into the breath. It's freaking free. You don't have to pay for your own breath. You don't have to ever be anywhere without it. You're not going to be like traveling and be like, oh shit, I forgot my armband or my whatever. You have your breath with you. You can literally and this is where a bit of my frustration comes from, is that why are we not teaching people this? We should be on platforms teaching this to people. Like you have said, there are people that experience such severe spasticity that it really impacts their day-to-day life. And it's so just heartbreaking to me that their only solution is let's cut the tendon in your arm to give you relaxation.
Rachel, someone tried to do that to me too. They tried to put my flexor muscles on the back of my hand. Yeah. And I said no. And I'm totally with you there. And yoga is not the only modality that integrates breathing. I can tell you right now that I integrate breathing into, and I already said this, I integrate breathing into almost everything that I do. It's a huge part of what I do. So what you may have experienced in physical therapy is what I call cookie cutter therapists. Hold on, Rachel, please don't interrupt. what I want to try to get input from Tom and John is do you guys integrate breathing into what you do? Tom,
All
do
the
you
time.
integrate breathing into what you do?
Yeah,
Sorry about that. I was on mute for a second with the cat and dog having an impending fight. So
Uh-oh.
so apologies for that. So yeah, I do, but I wouldn't say that it's a direct. It's not the headline of an activity. It's part of the method of delivery to it. I think breathing is important to reduce anxiety and tension, which can ultimately influence muscle tone. So it's part of it, but I wouldn't write a set of notes and say, completed breathing control, relaxation exercises as a separate thing. It would just be as part of the relationship that I'd have with a patient, if that makes sense.
Yeah,
I think typically the most often thing I find is that if people overstrain, they hold their breath as they're performing strenuous activities, and that can lead to abnormal tonal overflow. So a lot of it is about making breathing control is important for normal movement patterns too. So yes, but I wouldn't. It's not selected as like a standalone modality.
I
John, you touched on it before.
I agree with
that-
what Tom said 100%. Because working in the clinic, there's time restrictions, there's, trying to get certain things done. So there's a lot of restrictions, and I'm one in treatment to drop a lot of seeds. And I'd say, hey, breathing is so important. And there's people that make their living off of going around and teaching about the breath. And so there's a lot more to this. And so I'll point out different YouTube, TED Talks to people and say, explore this on your own, because it's going to be a lot more valuable to you, and it can be incorporated as a technique where you're exploring, and the brain will have a little bit more value to it, because you're going to find how it fits into your own routine. But to really impress upon them that yes, breathing is part of this, because we see as soon as anybody's challenged, a lot of times even the typical person, if they bend over to tie their shoes, they're going to hold their breath. It's similar to if you're looking for back in the day when we used to actually use maps to find a location. What do? We turn down the volume on the radio so we can concentrate. And a lot of times what we'll do is we'll hold our breath to concentrate. And so just being aware of this and utilizing the breath in our techniques, it gives us a lot more freedom, I guess, to do different things. I don't know. I mean, I'm kind of rambling here, but
sometimes there's a mechanical advantage to breathing too. Like I have individuals who, especially if they have a big gut or something like that, if they try to go sit to stand, they hold the breath, their diaphragm is forcing into their viscera and creating basically an airbag effect, blocking them from getting their head forward, nose beyond the toes, and obeying
Mitch,
body.
can you just clarify what was that you said that you're using? Because I think it might be called something different over here. I don't know what you were a big gutter.
So basically what I'm saying is if you can get in the individual to exhale as they're going forward from sit to stand, you are basically providing a cavity for the viscera to go up into the concavity of the diaphragm so that you can actually get yourself forward, nose beyond the toes. Nose beyond the toes is just getting your head forward to counterbalance your center of mass, which is your pelvis, to help you into sit to stand. I think
completely agree. I think I just misheard you, and I thought you were talking about a different standing aid that I've never heard of before. So it's okay. I just completely misheard you. That's all.
That's all right. Yeah, no, this is total like basic body mechanics. Nose beyond the toes, bringing your center of mass closer to your base of support. And when you exhale into a sit to stand, you are not only inhibiting opposing muscle groups from resisting you into the stand, but you're also mechanically allowing your trunk to go forward and not letting your gut get in the way. If you try to inhale and hold your breath and then go forward, you're getting your gut to mechanically get in your way, and you're not getting your head forward as much as you can with breathing. So, I mean, breathing can be inhibitory, it can be relaxing and parasympathetic, it can be mechanical, it can be for supplementing O2. In fact, I shouldn't say can, it is for supplementing O2. I have individuals with stroke survivors even who have difficulty breathing. They're breathing in their upper levels, and I have them take a deep breath in and actually do 1 or 2 pumps, and then all the way out to get them to use their full lung capacity for reoxygenation of their blood cells. So again, that's you breathe in, and then the top of the breath, and then blow all the way out.
Hopefully you're teaching diaphragmatic breathing.
That's integrated with diaphragmatic breathing. Absolutely. That is a component of that. So absolutely. So breathing is absolutely essential. So Rachel has one more thing.
I don't want to interrupt anyone, but I wanted to ask Tom, you said that you wouldn't necessarily write notes that breath was the focus of the session, but may I ask why? Why is that something that wouldn't be like the ultimate focus of a PT or OT session? Is there a reason for that? Is there just...
I think we just have a difference of opinion at the core of what our approach is. I think I don't know how to explain this. We wouldn't pick it because as far as what my training and expertise is, we wouldn't use breathing as a therapeutic modality. We would use it as a adjunct to the active participation therapy, whatever we're doing. But it wouldn't be, I couldn't, I'll give you an example. Like I've got a patient that might, let's say, have hemiparesis down one side. They've got a mild degree of flexor spasticity in their upper limb, but they can't move their left leg. They're currently assisted chaired. They struggle to stand up without falling over, with some perceptual barriers where they perceive their center off and they push themselves and all this sort of stuff. I couldn't just get them to relax and breathe and expect them to be walking in a few weeks. That's not what I would do. I would have to
say that it's more of like a secondary approach.
So it's an adjunct.
Yeah, I think it's a concept within what you would do to achieve, because it's all about facilitation of normal movement, inhibition of abnormal movement, and if relaxation is a component of inhibition, then it is important, but it is a aspect of a wider arching therapy session. The therapy session might be what I would term standing postural control rehab. So I've got a pusher, someone that, because they've usually had a right-sided stroke, when they stand up, they perceive their midline incorrectly, so that they overactively push themselves over. So my therapy for that patient will be correcting spatial awareness and body proprioception, what we would call it, in order to regulate activity and reteach where the central midline is. So that would include things like facilitatory work on the stroke side, stand and reach, exploring perception into the pushing side, adjustments of the base and progression. But if they're tense and they're holding their breath, that's going to interfere with their ability to follow the exercises. So it would be an instruction. You need to relax a little bit, drop the shoulder, breathe out when you go to do the attempt to reach. But the core exercise is still the postural correction. I couldn't just have them in the chair and go, I know you can't stand yet, your leg's not working, but let's do some. I don't want to. What's the word here? I don't want to reduce what you do, because I don't understand it to the degree you will. But I wouldn't. I couldn't just say do some, the breathing work and then see them functionally progress.
Well, the other thing here is Tom and Mitch and John know more about this than I do, but charting is something that you have to do on top of everything else. And they send you another patient. So They're not writing.
For me, it's not such of an issue.
To a minimum.
I think for me, it's not so much of an issue because I mean, we've discussed previously, Ralph, we have different systems here. But our company, with it being privatized, is you effectively manage how long you see a patient for. A client can do a 2-hour session if they want to do a 2-hour session. They could do a 1 hour, whatever. So we have that freedom, but it's just it's not what I would call, it's just not physio. That's just all I would say. It's just in its isolation, it's not what it is.
Yeah, it's a component of, and that's what I think John, Tom, and myself are all saying. It's a component of, but we need to have functional progression in our notes. We need to show measurable progress, and having breathing integrated into that is not a big deal. But we can't measure breathing. We can use it as an intervention to complement what we are trying to do with the individual, but that can't warrant progress. Progress has to be functional within our system of documentation. Functional would mean level of assist with a sit to stand, or supine to sit, or rolling, or walking, maybe quality of walking, the ability to increase range of motion, the degree to which that range of motion, but then again, that's not functional, but the functional application of the upper extremity towards a functional task. I mean, John, you know all about this. With regard to the upper extremity, can you think of any other measures for the upper extremity that we have to apply to OT?
No, I mean, I think you nailed it on the head. It's just, ultimately, if someone's going to be reviewing your chart, they want to see where they improved, how much they improved, black and white. And that's why I incorporate the breath. I really stress that there's more to it than even I know, and invite people to kind of explore that, because it can open up different pathways and doorways.
All right, fellas, I'm just going to say that I need to leave pretty soon. So, Ralph, why don't you help us wrap up, okay?
Okay. What do you want me to do to wrap up?
Well, if you want, I can wrap up. I just want to thank every single one of you for being on this. Rachel, Tom, John, Chris, Bruce, and Ralph. I think everyone contributed very well to this discussion. And so just to kind of wrap things up, what you really want to focus on, I think, with regards to overcoming spasticity, is to try to find ways to reconnect with your ability to foster activation and inhibition, whether it be yoga, whether it be bow bath, whether it be PNF, whether it be my TikTok inhibition, or double click inhibition and pandiculation. You do whatever you need to do to increase your range of motion, and then you apply it. That's really crucial. I think we all agree here that whatever you do to increase the range of motion, you can't stop there. You need to functionally apply it, and you need to functionally apply it in a meaningful way. So that's basically where I think we should conclude.
Okay, well, a couple things real quick. I'd like to thank everybody also. One of the takeaways I got from this was that, well, it's kind of back to like all strokes are different, all recoveries are different. You really need to look for or find a therapist that tries different things, and you need to be aware of how your body responds. Stroke survivors who develop body awareness, I think, do better than ones that don't. Why do they? I think there's more interest there, and we touched on that a little bit, but it's really key to pay attention and have a therapist that's paying attention to what's working for you and what's not working for you, and incorporate those things in your recovery plan. That was one of the takeaways I got from this. Anybody else?
That's been very useful.
Pardon?
Been very useful.
Thank you, Chris.
Well, I hope it's useful to everybody out there. And I want to thank Tom, Bruce, Mitch, John, Rachel, and Chris for participating. I think it'll have some value, and maybe we should do it again sometime.
Sure.
There I go. I can't help myself. What can I say? I'd be real interested in, my whole thing is, all my videos are set in my house with very little devices. It's basically you and your body, and how can you do things that don't involve a lot of devices, that work, that because I think that, well, back to mass practice, you're not going to get better in a therapy session a week. You have to put in your time at home. So I think the healing goes on at home, and therefore I've always taken that kind of a focus, because that's what worked for me. I got good rehab in the rehab hospital. I got spotty rehab after that. It wasn't near enough time. I put in tons of time, and I think that's one reason I was able to have the recovery I did in the time frame that I did. So if we can help other people through this conversation, or perhaps developing some videos that would reinforce some of these techniques, I'd be all for it.
Let me just say one more thing based on that. I think a great video to do would be an approach to your therapist, an approach to how to utilize your therapy most effectively. Because I could see, if I was a stroke survivor and seeing someone like Tom Haynes or John, I'd like to approach therapy as a tutorial, and I am going to ask as many questions as I can from that more knowledgeable therapist, and really pick their brains and really try, my goal being to become my own therapist. But I can't do that. Yeah, I have to get the training, and that's where going to physical therapy and occupational therapy is so beneficial. Is to really pick the brains of the therapist. Don't just go and just say, "What do you want me to do?" Okay, I'll do it, and don't be engaged.
Right. I would love to make such a video, and I've been kind of preaching this for a while, in that you should set goals. You should interact. You should be doing half the talking. You should get homework. You should do your homework. You should go back and demonstrate it. The therapist is like a piano teacher. And the whole point of this would be that, just like you have to learn how to be your own best patient advocate, you have to basically learn how to be your own therapist if you're going to put in the time effectively at home. And that's the way I got better, and therefore that's kind of my perspective on the way other people can get better. And it does not account for people who get like totally whacked with, a very difficult stroke that I know you guys sometimes see.
Brilliant, Ralph.
So I guess, Mitch, thanks for taking a bit of the lead on this. I didn't know you were going to do that, but it was very helpful. And again, I want to thank everybody, and I'll stick this on YouTube, and we'll put some bios and like links for Tom and things like that. John, if you got any links or something for your clinic, and be happy to do that. Same with Rachel. And that way maybe people could get some more information. And I'd look forward to doing a video, Mitch, on how to have the best relationship with your therapist, because it's going to come back on you, and how some of these techniques that I know you developed, because we used to do Wednesday nights for about a year, so I know a bit about them. How they could be, and I thought about it at the time, how do we bring these things in a practical way to people so they can do it at home? So with that, I'll thank everybody, and we'll see everybody next time.
All right. Thank you for your time.
Thank you.
Okay, thanks.
Do all you can with what you have, In the time you have, in the place you are, do all you can. Do all you can.